It's a great honor to be here and talk about my topic, treatment strategy of Ilio-femoral CTO. So, as you know, the Ilio-femoral CTO strategy is the same with the BTK and iliac. So, intraluminal, subintimal, reentry, transcollateral, distal puncture, and special situation sometimes. So, I want to talk about this strategy with the representative case. First, the sub-intimal angioplasty with the direct wiring. This case is very ugly. You can see the critical limb ischemia, SFA total, and below knee total occlusion. So anyways, we try to ipsilateral puncture with the micropuncture set. Fortunately, the Y is going down. And the sub-intimal angioplasty, as you know, put the Y intentionally in the sub-intimal space. You can see make a small loop and just push. Usually 90% success rate is reported, and the remaining 10% require the distal puncture or the reentry device. So we tried with the ipsilateral puncture and then glide catheter and subintimal angioplasty with J thermal, and the Y is going down with a small loop. And finally, we reached the distal room, and you can see the wire is going around the distal cap. And then, at this point, just pushing wire is okay. However, I wanted to try to minimize the CTO segment damage and beyond the CTO segment. So I wanted to try to the direct wiring. Start wire is very strong wire, so easily going down. So we reached on the road map. You can see the wire is reached the distal trap. And then we also meet another block. So I also try to intraluminal wire because of to minimize the collateral damage. However, strong wire cannot negotiate the CTO segment. So I try to puncture in the ATA segment. As you can see, usually the ATA puncture can be done with a micro puncture set. The CXI and commander wire is used. And easily going up. Recently, we can puncture anywhere in the body, as you know. So we can easily approach usual puncture point like this. So today, the first Dr. Ra case, I can recommend the AT puncture because of the popliteal puncture is somewhat difficult because of the no enough space. Anyways, we going up the wire, recommend the wire, and balloon angioplasty was done. And finally achieved good result like this. This is below knee artery. You can see the good flow. So I think this is a representative case of the critical limb ischemia. The next case is the reentry device. Recently, our technique is improved, so I usually use the reentry device. However, in the first initial experience of the SFA, I want to try the reentry device. So I show you some case. You can see SFA total occlusion and glide catheter was inserted, and this is braking cyst. And so we, after subintimal angioplasty, we confirmed the SFA ostium with IVUS. So just pushing wire. The wire is reached the distal lumen. However, wire cannot going down. So at this point, we try to the Outback reentry device. As you know, the L-shape, T-shape is very important to make the good adjustment. So T-shape, L-shape was made, and then just pushing wire. The wire is easily going down, and the balloon angioplasty was done. And some hedginess in this point, so we put the bypass stent at this point. So we achieved a good result. So this is the straightforward case of reentry device. This is another case of distal SF puncture. Very long segment CTO. You can see there's no definite stump in the AP projection. However, you can see the distal SFA, distal lumen. So ipsilateral area view revealed the SFA ostium exactly. So also we pushing with the command wire, subintimal space, and then I think that at this point, I wanted to minimize the damage, the vessel beyond the CTO segment. So ipsilateral distal SF puncture was done. So easily Y going up. The command Y is very useful at this kind of situation. So bidirectional approach was done. And then, as you know, the cut technique was applied. Balloon. So Y is going up. Contralateral catheter. And then balloon. So we finally achieved a good result. This is also the straightforward case of SFA total occlusion. So another case is somewhat different. This patient is suffering from the unhealed ulcer in the foot. So however, this patient, the history of the previous stenting in mid SFA portion, you can see the total segment of SFA include ISR total occlusion. So you can see the distal lumen located around here. So this point is maybe difficult to puncture. So anyways, I tried to subintimal angioplasty from the antegroidally. However, the wire cannot go into the stent site. So puncture stent with the micro puncture set, and the command wire also put the command wire is going up, and the wire is externalized with this catheter, and then balloon pushing to the in-stent portion, and the subintimal angioplasty, and was done wire, fortunately, going down to the distal SFA. So I achieved the wire passage, and then balloon angioplasty again. So we also achieve good results like this. So in-stent ISR portion, so sometimes the stent puncture is very useful. Another case, transcollateral approach. This patient is also good SFA, total occlusion, good collateral. So anyways, there's no stump AP projection. However, through area projection showed the stump here. So I think the ipsilateral area projection is very important to know the exact entry point. So anyways, the good collateral, so we tested several pathways. Finally, anyways, at first, we tried the reentry device, hardwire, all techniques failed. So we used the coronary corsair catheter for the collateral approach, and then Y is going up. Finally, Y is externalized balloon. And at this time, I enjoyed the stent implantation. Recently, I don't like the stent implantation. Anyway, at this time, I put the stent all segment balloon angioplasty, so showed a good result with the stent implantation. So I think there are some cases collateral approach is very useful. Another case is tibial puncture. So this is outside the angiographic finding from another hospital. Anyway, the SFA ostium and popliteal CTO. So check-in catheter and thermo is pushing. And then checked, I don't understand why that he checked the angiography. Anyways, make dissection. So in the CTO segment, I don't recommend usually angiography because of the make dissection propagation. So anyways, they checked the again and advance wire to the distal SFA, and on the balloon dilatation, he pushing the wire. I think that he maybe the wire is reached the distal lumen, and then balloon angioplasty serially was done. However, final angiography was make a disaster like this. So I think the confirmation of a wire tip is very important to before the balloon angioplasty. Anyway, this patient is transferred to our hospital. Check angiography again. You can see some flow here, and then popliteal total occlusion. So lateral projection showed popliteal lateral occlusion. This is ATA. So this patient is very difficult to distal SFA puncture. So I decided to puncture here. So under guidance of classification, easily can puncture. And this is nitinol command wire, advanced with the CXI backup support, and like this. So cut technique was also applied for the wire externalization, like this. Finally, wire is going up, and then balloon angioplasty was done, like this. So finally, we achieve good result like this. And then ATA puncture point with picks up with the blood cup pressure for 5 minutes or 10 minutes enough to picks up the distal puncture point. This is from the this is another special case. So you can see the iliac artery total occlusion. I cannot say exactly the common femoral artery. So this patient is a total occlusion from the iliac to the common femoral artery. So I wanted to touch the common femoral with the subintimal angioplasty because of to avoid stent the common femoral artery. These are SFP puncture here, and advanced with wire. This is a command wire, CXI catheter. So common femoral portion, I try to intraluminal approach because of to avoid the stent implantation. And also bidirectional approach was done. And finally, wire is going down, and then balloon angioplasty was done like this. So put the stent, iliac, and the common femoral artery was not touched with the stent, just the balloon angioplasty enough to maintain the patency. So I think the common femoral artery involvement, I think surgery is also a good option. However, in this case, intervention is also another good option. The very special case, bilateral aortoiliac CTO, post-SFA CTO. Very low ABI, post-SFA total occlusion, post-iliac total, post-SFA total. The patient refused the surgery, very old age, so I tried to puncture on the fluoroscopy. Both femoral artery was punctured with the 6 French. Glide catheter inserted, and the straight theorem was sometimes very useful, like this case. So fortunately, wire is going up to the aorta easily in the right side. And the left side also applied the same technique, glide catheter, small J straight theorem was also alternatively used. And then finally, we can make the wire passage. Both wires implanted the hard wire, balloon, both iliac artery was balloon, kissing balloon also done, and some heaviness and tight stenosis. So we put the stent here. And then I tried to, at that time, simultaneous all segment CTO post SFA. So I tried to the left side CTO first. However, at this point, we found some flow limitation in left iliac. So we checked the angiography, some heaviness of the left iliac ostium. So we put the stent both sides. So this is for the iliac final result. So at this point, crossover technique is impossible for the SFA treatment. So the patient was done post-stage PTA 2 days later. So left brachial puncture, and then insert the 5 French long sheath. And the distal SFA, you can see some segment for the distal puncture. So puncture here, command Y was used, and micropuncture set also used. So subintimal space wiring, and then CXI catheter is also very useful in this kind of situation. Wire is going up with the finally started wire is used. So wire externalized, and then balloon. So we achieved some good result like this. In second stage, right side the SFA also puncture here. The same technique is also applied. So easily going up, cut technique also worst, Y externalized. So balloon. And finally, we achieved a good result like this. So this patient, the ABI is much improved. And this is another last case, left claudication, recurrent SFA CTO. You can see the total occlusion from the SFA ostium to the distal SFA. Stump you can see, and distal SFA total occlusion. Below knee region is all okay. So subintimal angioplasty was done with the Rubicon microcatheter, and then reach easily to the distal lumen, and checking the lumen position, and we put the spider filter for the atherectomy. So this Silverhawk atherectomy was done several times. And then this is post atherectomy. Some dissection. However, we wanted to prevent the restenosis. I applied the DB. Because of this patient has have 2 times recurrent restenosis. DB is applied, so we could make a good result like this. So now we follow this patient. So I expected maybe good result. However, we need data for the 6 months. Anyways, in the SFA intervention, below knee lesion care is very important. The nerve vessel is influence the vessel patency. So if you to treat the SFA lesion, you must also care the below knee lesion. So this is my conclusion. Access site is very important. Subintimal angioplasty, reentry device, retrograde puncture in long segment CTO is maybe, I think, the default strategy. Bidirectional approach is essential for the SFA intervention. Run of vessel patency is very important to maintain the patency. And the role of DB and atherectomy in CTO should be addressed. Thank you for your attention.